Good morning, good afternoon, wherever you are, and welcome. Thank you all for taking the time to join us today. My name is Conrad Crump, and I'm the Manager of Government Affairs at Blue Shield of California, partnering with Blue Shield of California's industry initiatives. Blue Shield of California's industry initiatives works to advance healthcare transformation through industry collaboration and policy movement. In addition to our virtual events, we also host in-person events, produce publications, and partner with stakeholders from across the entire healthcare ecosystem. It looks like it's after 11 o'clock and we're ready to convene this fantastic discussion. But before we do, I'd like to provide a few quick housekeeping reminders. Please feel free to submit questions at any time through the Q&A box located at the bottom center of your screen. We've left some time at the end of our discussion for audience Q&A, and our speakers will try to answer as many of your questions as possible. We also encourage you to join in on the conversation. You can use the chat box for any technical questions, comments, or responses to the conversation that you may have, so please feel free to add your own thoughts at any time. In the chat, you can also check out the link to our website and sign up for our newsletter to learn more about who we are, what we do, and how we do it. Also, please note that this session is being recorded. Everyone who has registered will receive an email with a recording of today's discussion. If you were forwarded this event by a colleague or a friend, please be sure to go back and register so you can receive the recording, materials, links, and other pertinent information on our future events. And we went ahead and dropped that link for registration in the chat for you. So please register to ensure you will receive a follow-up message with the event recording. Also, we're asking you to head on over to Twitter to tweet out this event, share it broadly and widely, and make sure you tag the speaker handles. They definitely would appreciate that. So yes, we're excited to be here today, and we're really fortunate to have an outstanding panel here with us for the second in our three-part event series in partnership with the California Endowment. And we're hoping to shed light on ways to address social drivers of health through innovation and collaboration. The goal of today's event is to focus on how we can best collect, use, and share data to address social drivers of health and social needs. Most recently, we had a really great first event in our three-part series back in September that focused on workforce, and we actually have a video link for you in the chat as well. And our third and final event will be taking place on December 7th, which will focus on payment and financing. And you can also find a registration link in the chat for that one as well. And related to today's conversation, we recently published a white paper on how health plans can best support the collection, use, and sharing of social needs and social determinants of health data, based on interviews with over 40 stakeholders, including some of you who are actually attending the webinar today. A link to that document is in the chat as well. But without further ado, please let me introduce you to some of the pros who are in this space that will talk with us about addressing social drivers of health through data innovation and collaboration. We have with us today Adamika Arthur, the Executive Director of Health Tech for Medicaid. We have Linnell James, the HIE and Innovation Business Lead with Blue Cross Blue Shield Association. We have Jared McNaughton, the CEO of Inland Empire Health Plan. And lastly, we have Bill York, the President and CEO of 211 San Diego. And we will be hearing from them shortly. But before we dive into our great panel discussion, we're honored to be joined here today by my former colleague and good friend, Bonnie Midura, who is a Senior Program Officer at the California Endowment. She has been a terrific partner for us in developing this series, and she will be providing some opening remarks. In her role at the California Endowment, Bonnie manages a grant portfolio that includes both the Los Angeles region and statewide health systems teams. I'd like to invite Bonnie to join me on camera at this time. And Bonnie, I'll go ahead and hand it over to you.
Good, thanks, Conrad. Good morning or afternoon to some of you, and welcome. On behalf of the California Endowment, I am thrilled and pleased to be partnering with Blue Shield of California and their industry initiatives team to be hosting this second of 3 webinars, as Conrad outlined. For those of you who don't know, the California Endowment is a statewide health foundation founded out of the conversion of Blue Cross of California to a for-profit health plan back in 1996. We have evolved as a foundation over the past 2 decades from a funder that in our earliest years primarily funded direct healthcare services and policy advocacy to a foundation that now supports systems transformation by centering the voice and leadership of those closest to the health issue or conditions in their community in the decisions that improve these conditions. The conversation around data innovation within the context of social drivers of health is timely. It's timely as we have opportunities here in California with our Medicaid reform, also known as CalAIM, to better address holistic needs of individuals, not just their healthcare needs, but also these enabling factors such as housing and access to food that shape their health. It's timely as there's new tools and ways of integrating and reporting and analyzing data that are continually being developed. And today's conversation is timely as communities are strengthening their own voice and power to hold all of us, especially health system stakeholders, accountable for improving health outcomes. As a foundation, we have spent the past couple of years listening as we plan for our next decade of work, listening to our partners and reflecting back to them the data they have shared with us through their own stories as we shape our priorities for the next decade. We've heard loud and clear in communities all across California that folks want to move away from a health system built primarily upon healthcare services, or that comes into light when we need it, when we are sick or at our weakest, to really a system that supports health and wellness. I'm thrilled with the panel that's lined up today, and I encourage you to listen as well to the panelists and come away with ideas for how you can partner with other organizations in your own community, maybe within your own health system or across systems to advance this work. Working together, we can build towards this system of health and wellness that all communities deserve. With that, Conrad, I invite you back in and I'll turn it over to you.
Hey, thank you so much for that, Bonnie. As we've just heard from Bonnie, really unlocking the potential of data to address social needs and social drivers will require stakeholders from across the health and social care ecosystem to come together to achieve our shared goals. With that in mind, let's see who we have in the room with us today. And thank you all to everyone who completed the poll. All right, so today with us, looks like we have a majority of folks from the nonprofit industry, followed by a large portion of individuals from health plans. And following that, we have other folks from the policy space. And then also a smattering of some other folks who consider themselves other. We really appreciate all of you for being here today. So at this point, I'd actually like to invite the panelists to join me on camera. These are the experts who will be with us today to have our discussion and answer some of the questions as we dive in. So now that they are joining me on camera, I'd actually like to ask each of them to give us a brief overview of themselves and how addressing social determinants of health fits in with your work. Firstly, I'd like to go with Adamika. We can start with you, and then we'll go to Linnell, then Jared, and then Bill. Adamika, go ahead and take it away.
All right, good morning or good afternoon to everyone. My name is Adamika Arthur, and I run a nonprofit called Health Tech for Medicaid. I'm an epidemiologist by training and was a hospital leader in Northern California for a very long time before starting Health Tech for Medicaid, which is a bit between the marriage of health equity and tech equity and where we meet. Health Tech for Medicaid is dedicated to supporting innovation in Medicaid. And our purpose to do that is through improving quality, equity, and access to care for Medicaid recipients, their caregivers, families, and ultimately all of our communities. We kind of do that through a few ways. One is through service delivery, innovative program design. We build an infrastructure and an ecosystem. So when I started Health Tech for Medicaid, we didn't have this bridge. And then we do a lot of work with entrepreneurs, payers, providers, policymakers, advocates, investors, and others in the Medicaid community. Thank you for having me.
Hello, my name's Linnell James. I work with Blue Cross Blue Shield Association here in Chicago. It's November and I realized, guess what? It was 20 years ago in November that I started with the association. 2 weeks later, they sent me to lovely Detroit, Michigan to learn 3 days of what's an X12 TR3 for the HIPAA rule. Since then, I've been able to have a lot more fun by working with HL7 and being involved in all things related to clinical data exchange, and now part of the Gravity SDoH project that's involved in health equity. I'm also involved in Fire at Scale Task Force, which is involved in using APIs for healthcare and taking full advantage of the technologies available. I'm pleased to also say, as part of my history, I spent 5 years at Cook County Hospital as the Deputy Director of Clinical Systems. And as part of my work here at the association, they allowed me to volunteer for 5 years with the Office of Minority Health under the Obama administration, the Great Lakes Regional Health Council. I was actually the co-chair of the Social Determinants of Health Committee. So I'm actually living the dream. I'm working on technology standards, improving healthcare, and actually doing health equity, not only at HL7, where I'm on the board, but actually at the association, as I'll share later, where we have a national health equity strategy, and I'm part of that team. Thank you.
Well, thanks, Linnell. It's great to be with all of you folks today. My name is Jared McNaughton. I'm the CEO of Inland Empire Health Plan in Southern California. We're one of the top 10 largest Medicaid health plans in the United States and the largest not-for-profit Medicare Medicaid plan in the country, and just celebrated our 26th year. I have about 1.6 million members here in Riverside and San Bernardino counties who are enrolled in both the Medicaid program or our CalMedi Connect dual eligible program. About 6,000 providers and about 3,000 employee team members. Obviously, this panel today that you're going to hear from, incredible work that all of these folks are doing. We're just such a joy to be part of this. For us, the social drivers of health are incredibly critical to understand how to deliver the right care at the right time in the right setting. And for our organization that is serving communities here in the Inland Empire that have really tough rankings in the state of California when it comes to social drivers of health and the county health rankings in California. This particular topic is incredibly important to us as our team focuses on how to meet our mission to heal and inspire the human spirit here in the Inland Empire. Great to be with you folks today.
Good morning, good afternoon, everyone. Bill York, the president and CEO of 201 San Diego. Very excited to be here with all of you. Many of you might know I have 201 San Diego is an INR provider in San Diego County and Imperial. The information referral business is really at the heart of what we're at. I joined over 15 years ago when a small little nonprofit received the dialing code and during a fire was activated for disaster response. And I found it fascinating coming from the corporate world of providing information and referral to credit card holders and to, again, people gifted with wealth and talent, and to find really what a disjointed system of connecting people to resources they needed. You can imagine the science of knowing what a person's information is needed for eligibility and connecting to the resource that matches it to the system and getting that right the first time. I found it fascinating. And so I've stayed on that journey here for 15 years as we've grown 211 San Diego and our community information exchange of looking at not only what the people to people it is with our services, but also the community layer of the housing sector, food sectors, and how those linkages work to actually to government, healthcare, and larger services. So I think I'm excited to talk about all the different things that we're doing that work directly. Again, we didn't even know we were working in the social drivers for health for a long time until we actually started examining more. It's something we've been doing for many, many years. And so happy to share all the things that we're doing in San Diego and the community health community information exchange today.
Wonderful, wonderful. Well, thank you all. This is going to be great. Let's go ahead and dig a little deeper into some of these issues. I'd like to direct the first question to Bill and Adamika. Why is leveraging social determinants of health and social needs data so critical to addressing social drivers? And can you frame today's conversation a bit more in terms of how these data can be used to drive improvements in care delivery and health outcomes? And what are some of the key considerations for effectively putting this data to use? And Bill, how about you start us off, and then we'll hear from Adamika.
Sure, happy to. So as I was mentioning, I think, being an INR provider for such a large county of 3.4 million people, and just that the number of people that represents in looking for services, we have a really special perch to see a supply and demand. So if you think of the demand, the number of callers or different ways that people contact us looking for a service or multiple service to match their unique needs. So understanding that volume, and if you think of the capacity or the size of that, growing from 68,000 calls or contacts or people in 2007 to hundreds of thousands in 2022 and over 1 million during COVID years. So if you imagine having all of those live interactions with people, the data that we gather on them, again, for the necessary needs of matching eligibility, that could be race, ethnicity, income, family dynamics, housing, geolocation, education, because it's not about having 6,000 programs and resources in San Diego. It's about whether you can access them and whether you're eligible to receive them. So if you think of having to know, one, about the client you're connecting and that engagement that our people-to-people contact has, and then knowing with 6,000 agencies, programs, and services, how to connect them, that's an incredible match to make, and to make sure that's right the first time. And so, it's our responsibility not only for the community to collect, aggregate, and share insights across that, it's our responsibility because that's the proper way to get people connected, not only whether they can receive the service, but the pathway and the outcome. So we've had a long journey. And again, being an INR provider, being a 211, and having that sheer volume allowed us to actually use that data to make great change. Over time, we realized it's really not just about our data or knowing our person. And at one time, the industry of 211s was an anonymous call, if you could imagine that. So imagine moving to a person-centered, that we're working around that person's data, that's person's specific uniqueness, and then the programs that would match to that, and then what were the outcomes of that. We saw a pretty disjointed system, and that was sometimes within ourselves, right? What questions we were asking, what did we need to know? Were we making the right referrals, meaning did we ask the right questions? And so, and how did we bring that together? And then at the same time, we saw some disparity of what the community approach is, that sort of meso layer of, how are people accessing the program? We can refer a whole host of people to programs. Well, what's their capacity? What's their intake, their hours, and operations? So it really explored that our role as a 211 and information referral provider expanded more to like helping our nonprofits working at the systems level in our community of having people access correctly, and also finding the barriers. And so over the last 15 years, again, we've changed, we've innovated. And I think that's where you'll hear a lot about our community information exchange. Realizing there's a macro level layer needed in sort of systems change. We know that many nonprofits, community-based organizations and services were also accessing the same client. We're working with them at 211, we're working with them in housing programs and food programs. And so we knew a single longitudinal record was necessary to see the golden pathway, that pathway people were taking to either accessing or not necessarily accessing services. So, with our CIE platform, we've been able to create a longitudinal record across 127 organizational partners that can share with consent of an individual to share their information, to see the information, to act on and create interventions for clients individually. At the same time, seeing what the system approach is. Does one agency need to be lifted? Does one have a capacity? Does one need, so whatever that might be, and really the data aggregation of that. Watching our callers go through and citizens of San Diego follow a pathway through the Community Information Exchange, we can see great outcomes of what that data does and changed. I want to give you one example. For a long time, as being an isolated sort of information referral provider before the systems were created, we long knew that utility assistance and access to paying utility bills was a possible pathway to something future going on in the future of housing and homelessness, because people started their journey with us on the back of their power bill by calling 211. Until our systems were linked and we had more aggregated data to the housing and to our calls, we have now created a housing instability report that actually shows us the pathway of the first touch for utility assistance to then a shut-off notice, to then rental assistance, then housing that actually leads to potential homelessness by a certain percentage over a 1.5 to 2 years time. That data across sectors has really allowed us to share again with predictive analytics, as well as create a CIE with local governance, data ownership, and an opt-in model for data across our sector. And so really using data and the social drivers of health have really met a path for San Diego and CIE. Thanks.
All right, passing it over to you, Adamika, if you can kind of share some of your thoughts and responses to the questions.
Yeah, well, it's great to hear from Bill. And I think one of the things I have learned in my career, starting out as an epidemiologist and kind of deeply in the public health space and transitioning actually through Medicaid, the expansion of Medicaid in 2005 in the state of California, is what had me become a hospital leader. And so through understanding the inside four walls of the system, the care system, and the payer and provider tensions and all of that, one of the things that in starting health tech for Medicaid I really learned was our definition, our terms around health equity are all different, and we speak very different languages. And I think that's one of the things that's very exciting about being here today. Health equity to me and to many is really a broad and complex topic, really, that really just focuses on having fair and just opportunities to be as safe as possible. And where that intersects with social determinants of health, and I think we kind of do a misnomer by saying social determinants of health, because they really are environmental, economic, political, and social determinants of health. I actually tell people that health equity really entails focused societal efforts, right, to address avoidable inequalities by equalizing the conditions for the health of all groups, including those who have experienced socioeconomic disadvantage and those who have had historical injustices or current injustices. And I say that because one of the tools we have been utilizing and helping as a convener the vast majority of folks who spend time with us, from private equity and venture capital to technologists who are developing products as entrepreneurs, to the health system, the traditional health system between payers and providers, and also looping in policymakers, is really around inclusive and equitable design. So in some cases, we are going to have to redesign systems that are actually working as they were currently intended. And because they're working as they're intended, they've actually created a lot more challenges for us moving ahead. And so when I talk about inclusive and equitable design, people are kind of a little confused, but you're not an architect, or you're not a designer. I reframe that by saying I am a designer. I'm an impact designer. And I believe that everyone on this call is some sort of a designer. And I think we need to really reclaim these terms, because when we take that interdisciplinary approach across a wide variety of fields, whether that is industrial engineering, which in the hospital and health system settings, we use Lean and Six Sigma and all of those tools, healthcare, but also finance, we're really getting an opportunity to take a stab at some new competencies that we can all use well, And when I look at CalAIM and the community supports that incorporate SDoH into care plans that are going to come ahead, we've been talking about large things like housing support, post-acute care and placement, day health programs. In order to do that well, we have to really design systems better to help individuals with complex health needs and to help them with unmet social needs. And I think that really requires many of us being at the table together and to looking how we connect social determinants of health and inclusive and equitable design together. Ways in which we can do that are really done through looking and talking at our systems in ways that we have not really traditionally. How often do we talk about education, access, and quality as it pertains to our individuals seeking healthcare? We don't. But quality education is a fundamental pillar of life. It also is something, as we talk about maybe lifelong learning, that all of our continuum and our workforce actually needs. So having those different sorts of conversations be a part of our healthcare conversation is going to be really critical in order for us to not currently meet our needs, but also to be able to communicate with the folks that we're working with, but also retain our workforce and gain new skills of individuals who are coming into our workforce. Another one, we've talked a ton about healthcare access and quality. And undoubtedly, that's a huge step for us in addressing these healthcare disparities. But I think we need to look at differences in how we utilize technology and tech enablement to really help us with health communication and the delivery of clear messages, not just from an engagement perspective, but also a satisfaction perspective. Sometimes we bifurcate one thing for another. And I do want to say tech is not the only solution. Oftentimes when people say health tech for Medicaid, you're thinking only about technology. No, I'm looking at technology as a tool. But in a social and community context, we need to think about how we leverage access to a variety of tools to allow for people's relationship to care, which sometimes is through a conservator, sometimes is through a family member, other times is through a caregiver. How do we create relationships, a sense of safety, a sense of belonging into tapping into health and wellness from a culturally competent perspective? And the last thing I'll end on is really around neighborhood and built environments. We all know fundamentally that our life expectancy is tied to our zip codes, but we often stop the conversation there. If we start to look at inclusive and equitable design of our policies, our programs, and our systems from a data perspective, we're going to have very different conversations as it pertains to our economic stability in the built environments in which we're creating and that we currently have. Thank you, Conrad.
Wow. Yeah, that's very powerful. Thank you both, Adamika and Bill, for your words and for your work. That's quite amazing. Turning to Jared and Linnell, I'd like to direct this question set to you too. While social determinants of health and social needs data can be powerful tools to addressing social drivers, there are significant challenges to collecting, using, and sharing these data. Can you discuss what these barriers are and share any best practices or innovations you've encountered to address these barriers to unlocking social determinants of health and social needs data? Let's go ahead and start with Jared, and then we'll hear from Linnell.
Yeah, thanks so much, Conrad. It's a great question. And, it's interesting here in our organization at IHP, working with providers in the community, as I mentioned, about 6,000 or so, to try to collect that information and data, Z codes and other very, very special data for our pay for performance programs, and of course, the priority codes from our friends at the Department of Healthcare Services. But it is very fascinating with the lessons that have been learned over the years in a region like we're in here in the Inland Empire. Very similar to what my previous colleague here, Adamika, just shared, that she was in the hospital world. I was in the hospital world prior to this role as well, and was the CEO of an academic medical center back east called Kettering, where all of the clinically integrated network that we had was pretty easy to pull data and pull those Z codes and the information for the state and our friends at the federal government. But here in the Inland Empire, I'll tell you, when I came here about 4.5 years ago, it's been a whole different rodeo. It's been incredible with the lack of connection that we have here in the IE. We have to work with over 300 different EMR systems that are in this community to try to pull that kind of data. And as you might guess, when you hear that kind of a number, over 300, you can imagine that some of them are homegrown, some of them aren't supported anymore, some of them have been around for decades, but they're just not even able to get in to change any of the coding. And so for us, despite being able to always have access to those Z codes through some of the EMR systems, we've also really tried to make sure to encourage providers to actually document and use the Z codes in their actual documentation, whether they're still on paper charts or even in some of their notes. And we found that when our team goes in to try to do reconciliation on some of that data, it really helps to make sure that the provider team understands the nuances to some of those coding challenges. And in fact, we just hosted here at IHP about 100 of our providers to talk about our new pay for performance program, the importance of coding. And we had 3 providers that were in the 75th percentile of performance share best practices with their colleagues about what they could be doing, real practical tools in their offices to understand why those codes are so important and why it's incredibly important to actually help drive understanding of the social drivers of health much more. So for us, all of those conversations are going on at the same time. We want to make sure that we're using all of that information that we get in a way that is incredibly high on the ethics side. We don't want to ever unintentionally create more disparities in how we actually are pulling data. And so to address and make sure that we're really using that data correctly, we've actually started to address algorithmic bias head on by partnering with experts to examine our own data algorithms on how to make sure that we're mitigating for any of the bias or disparities that might be generated by them. And there'll be some more information coming out soon with a published article on that from our team, because we found that sometimes in some of our formulas that we look at through the data that's pulled, we can actually, it actually has an inverse effect at times that we're actually not mitigating that bias for the disparities. So something for us that's really on the top of our agenda, and some great work by Dr. Ed John, our Chief Quality Officer, and others to help address that. Also wanting to make sure that, of course, the governance and the process that's in place for the ethical use of those data elements are there. And we're really very fortunate to have a phenomenal partnership with Blue Shield and others in the market for a statewide HIE, Health Information Exchange, called Manifest MedX, who's helping to pull some of that data together in a way that is pretty remarkable and helps to address some of those issues. And so it's just a joy to be with you folks today and share some more of that here in the future. But Conrad, thanks for letting me share that.
Sure thing. And I'll go ahead and pass it over to you, Linnell.
Thank you. I'm going to build on something Adamika pointed out, which is the technology. And yes, it is a tool, but boy, is it a powerful tool if we can figure out how to wrestle that thing to the ground and take advantage of all of it. Let me focus on some of the challenges I've seen, also some of the opportunities for the technology, and share some information. And for those of you on the call, don't worry about taking notes. I'm going to pass some stuff back to this team so they can share it with you after the recording. But one of the challenges is just interoperability and taking advantage of the API economy. Everybody knows Amazon.com, everybody knows hotels.com. That technology called an application programmer interface, APIs, it's on your phone. You use it all the time. It's how you do Twitter. Well, now it has come to healthcare. Fast healthcare interoperable resources, FHIR. It's the way we're taking advantage of technology that exists and repurposing it to healthcare. And with the Gravity project that I'll share later in this session, it's the SDoH approach. So it's not just interoperability for healthcare, but it's interoperability for the social determinants of health are now part of that ecosystem. Now, the challenge is everybody knows we've got these disparate silos, and we know we want them to talk together. And boy, have we made some progress with the HIEs and the fact that the feds have made some rules that make sure the EMR vendors use the best technology for the health systems, and the payers have a requirement to exchange with their members. So yes, we've got some levers that are helping move the industry forward, but guess what? One of the challenges is you have to get that all the way to the community. You can't really tackle health equity until you're in the community. Doesn't happen at your desk, doesn't happen on a computer. It happens with a ground game. And that's a challenge for this industry, to have large institutions like payers and health systems interact with community-based organizations. As Bill knows, it could be a challenge. However, we're talking stuff you can do on your cell phone, things you can do on a laptop. So now all of a sudden, I can interact with a faith-based church that has a health minister who has a laptop that actually has the SDoH survey based on Prepare to capture that information. So when you're interacting with Bill's 211, you're actually in a position to know and have surveyed that information. So that's one of the things. The other challenge is HIPAA hasn't kept up with us. HIPAA says HIPAA covered entities can talk to each other. Well, guess what? Community-based organizations aren't HIPAA covered entities. And unfortunately, some lawyers at health systems are like, oh yeah, you're working with them and it's for the benefit of the patient, go ahead. Others have said, oops, I'm sorry, you're sharing PHI, PII, full stop. The Office of Civil Rights in Washington needs to clarify that so the whole industry can recognize SDoH data, race and ethnicity data, SDoH data, all needs to move, and it needs to move to the right stakeholder, and they need to get the regs aligned with the needs of the community. Is just a thing I'm aware of, and we all need to work on that. But one of the things I'll highlight is the challenges is making sure people are taking advantage and knowing where this is. A lot of people don't have time to follow HL7, follow Work Group for Electronic Data Interchange, keep up with the rules coming out of CMS, keep up with NCQA, keep up with JACO. Every one of the organizations I've mentioned has an initiative for SDoH. I guarantee you, if you go out in a large city and ask somebody, they have no clue that the federal government is making these moves. I know there's quite a few payers on the call. The association, all 34 CEOs last year said, we're going to tackle health equity, and identified the ways we were going to tackle it. I can tell you right now, it's still a challenge. As I work with the 34 Blue plans, the CEOs may have said, yep, we're all in, but not every single department is singing off the same hymn book. Same thing with the large health system. Somewhere in every health system is somebody really moving on SDoH. But is that person aligned with the IT? Is that person aligned with the communication with their partners? Because everybody on this call has existing partners, but are all the partners working off the same hymnal sheet about how they're going to collaborate, whether it's technology, whether it's outreach, whether it's common engagement? Part of our challenge is to get all those boats moving in the same direction and getting some of the barriers out of their way so we can make some progress. But that's some of the challenges I've seen, and the fact that there is some things happening. We just need to have more information shared, which is part of what this call is trying to accomplish.
Wow, thank you so much, both Linnell and Jared, discussing that aspect of technology and highlighting some of those connection points and challenges. I really appreciate your wonderful comments. At this point, I want to kind of shift the conversation a bit. And as we think about how to move this work forward, I'd like to ask each of you to discuss the role of partnerships. And I know some of you have touched on that a little bit earlier. But I guess my question is, how do we work together to advance the collection and use of social determinants of health and social needs data? And kind of in a rapid round, we'll ask each of you to go around. And Adamika, we'll begin with you, and then we'll go to Bill, then Linnell, then Jared. Can close us out. So Adamika.
Sure. So we are a convener. So I think a lot of this is how do we bring together conversations that we typically don't have? And I think a nexus of that. So Medicaid's done 56 different ways in this country. And when I say that to people, they get a little shocked and dismayed. But that's a lot of, as Linnell spoke to earlier, we've got a lot of federal work to do, right? The federal is the floor of our Medicaid program. The ceiling is the state. In this case, it's Medi-Cal and it's Cal-AIM. And I think that we've seen health plans that are early SDoH collaborators, but we definitely need more involvement. There's been a lot of chatter in the chat around community-based organizations and how do we get involved and how can we be invested in these SDoH initiatives. And I think that there's value of SDoH initiatives when you look at the categories of determinants of health, but also we need to measure that, and they need to measure that through health impact, because oftentimes these collaborations aren't measured. I think that starts with something as simple as race and ethnicity data. We've been working with many states, Oregon, New Jersey, others, and language and race and ethnicity data is the first way for us to actually get more information about our communities. I think creating productive partnerships is going to be essential. And that may mean we need to have some universal alignment on objectives for these SDoH initiatives. Can I keep going or do I need to rapid fire it away?
I'm happy to jump in.
Okay.
So, it's interesting from the three other guests today, they hit so much on, I think, the partnership pieces in what they said, the partnership with the CBOs, again, their providers. And I think one thing that we have learned in our community information exchange journey, which we've been working on since 2011, 211, naturally, all of our resources and our databases are partnerships, where we partner with those organizations to be listed and be able to refer to and work through. Well, as we found that we were trying to, again, connect the tissue to that and create that pathway, much like a health information exchange. I think Jared mentioned all the disparate systems. I mean, the logs, the Excel sheets, the way that different providers are working. We know nonprofits are 20 years behind in technology. Even a shared language across sectors, right? Housing sector, the homeless management information system sector, food programs. There's no one standard. There's no connectivity. Technology's behind, and again, I'm also under-resourced. And so what we learned is actually that, everything we've done in 211 and CIE is collaboration. And we really need to put that for, again, the shared language, the governance. So beyond 211's San Diego CIE Board of Directors, we have an advisory council of community-based organizations that discuss and talk about the ethics and what a closed loop referral looks like, the data. We also work and embed into the change management at a service provider. If your admin person is answering an intake call for a program for your organization, then how does that work into the collective system of someone accessing a closed loop referral and following the pathway and shared data? So I think it's all of those things that community outcomes groups and things like that come together to bring, again, and we know the community-based organizations are probably some of the places where some infrastructure is needed, some standardization, again, and shared language. And that's one of the things that we have really shown through the Community Information Exchange locally is what's needed to bring that to scale on a national and links to the healthcare world as well.
Great comments, Bill. And I think what I would add is part of the opportunity here to collaborate. One of the underutilized organizations is faith-based institutions. And I'm going to add that in addition to my role as being a payer advisor to the Gravity SDoH project and the payer advisor to value-based care, where this issue of how do we make sure we're connecting the cost of services to the delivery of services to reducing the burden to the providers, we need to take that all the way to the community-based organizations. And those Z codes, the Gravity project for SDoH, a year ago submitted through the National Committee for Vital Statistics process at CMS Z codes for SDoH. Most people don't know there is a Z code. Part of the challenge is it's approved by HIPAA, but there's no requirement to pay. I can tell you one of the blue plans, and it's public domain, Highmark doesn't pay for the Z codes, but if the Z code comes in from a provider, it goes and it becomes part of the value-based program, and they're tracking it through that use of Z codes. So people are being creative now that there are those that know that there are Z codes. There are also SNOMED codes and LOINC codes, which are again standards for the industry for technology that for over 2 years they've been pushed into the system. But again, most people aren't aware. But here's the news that helps in terms of collaborations. Robert Wood Johnson just provided a month ago $1 million to do projects through HL7 and a group of collaborative organizations that are working to implement the use of standards-based technology in the field with community-based organizations. That the press release just happened a month ago, so it's hot new news. And of course, the Congress is in this too. The House is approved, and I believe it's at the Senate. There's going to be congressional action. I mentioned before there's CMS action, but getting back to the context of collaboration and working with the church. Faith-based organizations have health ministers. Health ministers go with a comment that was in the chat about what about community-based navigators? Well, in Chicago, there is a group that's working with community health workers and a different group that's working with churches, and I've connected the two of them and said, excuse me, could you guys work together? And oh, by the way, there's some technology we can use to help you. Oh, and it runs on a cell phone. Oh, and the mayor of Chicago has a initiative because she wants to get reelected again. So she has a 5-year plan to improve Chicago, which has an entire chapter dedicated to social determinants of health. And there's state and city money dedicated. So I encourage everybody listening, there is foundation money available. You have to be a little innovative and creative, but I've given you some real good points. There's standards you can use. There's payers and providers that want to work with community groups, and you just have to be a community group that has a plan and has the ability and vision to take advantage of all this really cool technology we created back in Techland that Robert Wood Johnson's saying, push this out, don't hide it, make it usable. Part of this, I think what we're accomplishing with today is helping people understand there's federal support, there's funding out there, but it's important. You can't do it alone. You got to be a coalition and take advantage of some of the real powerful community groups that are faith-based and non-secular. One last point, and then I got to turn it over to Jacob, which is even the American Heart Association is in this because they've got a coalition that wants everybody to exercise. Well, if you want to be healthy, you better be moving and walking around. They're trying to take advantage of technology and coalitions to support that too. So coalitions are the way to go. I'll make sure there's a link that will go in that talks to a white paper I did on coalitions. Thank you. Jacob, I think it's you. Jared.
Thanks,
Thanks.
Linnell. Yeah, no problem. Yeah, I couldn't agree with all of my colleagues more. I had a mentor once, Dr. Lee Kaiser, share with me, you lose your soul when you disconnect from your community. And as Linnell shared, I'll tell you, that could not be more true in all of the communities that we serve. And we see that firsthand on the unique differences, even literally going from one block over to the next block and the massive differences that happen. And as Adamika shared, one of the greatest things I think to happen in California is actually CalAIM to almost push and nudge all of the health plans in the state, whether a local initiative, a public entity like ours, or whether some of our partners like Anthem or Molina or Blue Shield or others, to really start to focus on creating those partnerships in a way that are boots on the ground. And I'll tell you, Bill was spot on this, because when we started to look at the CalAIM framework, which is the most transformational thing to happen to the state's Medicaid program in the history of Medi-Cal here in California. I couldn't agree with you more, Bill. When we were working with those community-based organizations, so many of them didn't even really know how to literally complete an encounter that could actually be then sent to us, the health plan, through any of their systems to actually get credit for some of the work that they're doing. And we really had to get out and have those boots on the ground, learning from one another about how we can support that work that's happening on the front line of the community, and at the same time support the unique data needs that the state has so that they can get a bigger and better picture of really what's happening. So I'll tell you, Bill, I have to put in a plug for you, because our team has shared with us that the work you folks are doing down there is remarkable, in fact, best in class. And I know we have our Connect IE platform that's a free online platform that connects residents in both of our counties to community resources. So much of that was actually really created and helped to be brought forth by Bill and his team down in San Diego. And those kinds of sharings and learnings from one another, I think, is really what's going to be the key for the success for all of us.
Wonderful. Wow. That was just a wealth of information. Thank you all for this wonderful conversation. I know we're getting close to our time. So what I'd like to do now is move into the question and answer portion of this event. Again, we're trying to get to as many questions as we can. And if anyone has any remaining questions or wants to follow up after the event, please email us. We have a link provided for you in the chat. Our email address is industryinitiatives@blueshieldca.com. But I'll go ahead and go into some of the questions at this point in time. And a question for you, Jared and Bill. What thoughts do you all have on the California Data Exchange Framework on improving health equity and community of care and better addressing social determinants of health? And Jared, let's start with you, and then we can turn it over to Bill.
Sure. Yeah. This is a big deal, of course, for our state to really push our friends in Sacramento to get on the bandwagon of this kind of data exchange and sharing of information. It hasn't been as easy as I think all of us had hoped for. I think we were all hoping that the state would really take even a more leadership position, especially as Linnell was sharing, to capture some of those federal matching dollars that are available to California, which we have yet to take advantage of. I would love to see the state take a bigger leadership position on that, Conrad, to really push all of us within the healthcare sector to say, hey, it's the right thing to do to make sure we're sharing data that, of course, is owned by the patient or the member. I mean, it's their data. And if they want it to be shared so that they can actually have a better, more full wellness and healthcare experience within the organizations that they're served by, I just think we have to do that. And so I'd love to see a little bit more of a push there and leadership from the state. Bill, I'll turn it over to you.
Yeah, and transparently, I was able to spend over a year working on the data exchange committee in Sacramento with that committee and talking about these linkages. And it was obvious that it was very healthcare centric, lots of HIEs, and as nonprofit and as community information exchange, it was important for us to keep putting forward this social care data linkages. And so many of the things that we've just spoken about disparate systems, codes, all of those things were spoken about as how does this play out in the future? Where does this all lie? Is it HIEs? Is it health plans? Is it with? And so I think for ourselves and who are watching again on the community information exchange, the linkages to health information exchanges and all of that, is that we're really hoping the state will come out stronger as well. With, I think, making sure that there is a process and a platform that really integrates both, that again can equalize the playing field for community-based organizations, those faith-based organizations, to get involved in sharing that care that they're doing so much of the lifting for social care programs.
Wow. Wow. That's awesome. Yeah. Thank you very much. And actually, in a follow-up, I'd like to ask Adamika and Linnell, what are your thoughts on having a single set of guardrails for data sharing in the state? Are there tools that are needed to lift all boats, especially for our social care providers? And I'll go ahead and you can go ahead and start, Adamika, and then we'll pass it over to Linnell. Kind of in a lightning round. I'm trying to get to as many
Sure.
questions as
Yeah,
possible.
I totally get it. I'm going to
Okay.
go really quickly and say that some of it is collecting data, right? And actually
Absolutely.
using that disaggregated data well. Oftentimes we do things, and here's a great example. We take race and ethnicity and put them together. They're very different. And
Right.
actually, when you put race and ethnicity on the same slide, and I'm an epidemiologist, you actually remove people from racial categories to actually put them in the ethnicity category. So that's not what we want to do. We actually want to have race data and ethnicity data, even if the ethnicity data is I'm Hispanic with no race, like if you don't identify with being Black or white or Asian or a true race category. So I think some of it is using real race, ethnicity, language data, and other data so that we can actually determine who is disabled in our population. What sort of disability does that look like? Is it an accessible disability? Do they need other supports? But when we don't have the data, we actually cannot redesign these systems well. And I know people have talked about us indexing on kind of the most critical, and a lot of CalAIM is focusing on the sickest, the most, kind of the outliers, as some people would say, in the bell-shaped curve. And I think by having really good data, we actually can move towards the middle of that curve and design systems that are a bit like crosswalks, right? Right now, when we all cross the street, we can pretty much cross the street in 99% of America because it was built with the lowest common denominator and in mind first. And so that's just what I would say to start with, kicking it off to Linnell for guardrails.
Well, one of the guardrails, in fact, it's so funny because just last night I had to take my class on protecting data, and lo and behold, when I looked at it, it's like, oh my God, race, ethnicity, and SOGI data, sexual orientation, gender identity, they're already recognized by the government as a protected class. It's not the same as HIPAA data, but it's pretty close. So the issue is most people, I don't think, know it. And one of the reasons I know this, and I'll wrap up, is because we did a survey, we, the association, hired a company, and we actually talked to 40 people, interviewed them, talked to them. And guess what we found out about race and ethnicity and language? One, race and ethnicity, they're like, I want to make sure you're protecting it. Well, guess what? We actually already are. We just don't always know that we've got these protections in place because the IT guys take care of it. Trust me, if you're a large shop, you are already taking care of that data because you have to. The federal government has already mandated that, but not everybody knows it. So it's really important to communicate to consumers that your race and ethnicity data, your SDoH data, is being carefully handled. And the other thing we learned was you got to tell people why. Why do you want this data? For some of you who are payers, you already know, people don't realize we have case managers, we have advanced analytics. We're all about trying to keep you out of the hospital and trying to make sure you get preventative care instead of expensive ER care. But they don't know that. So you've got to communicate a clear value picture that says, I'm interested in health equity, I'm interested in protecting your data, and I need this data to do a better job of keeping you healthy. People in general don't know that payers and providers are doing that every day, but they need to hear it explicitly as part of moving forward. Thank you.
Wonderful. Thank you so much, Linnell and Adamika, for touching on that question. I have so many more questions that have been brought up, just from this discussion, but obviously we don't have time for that today. But I want to actually just take the time to thank our panelists, each of you. I also want to shout out Bonnie, give a special thank you to her and the work of the California Endowment. And thanks to all of you for joining us for today's session. What we'll do is look to follow up with you in the next few days with a recording of today's event. Again, please make sure that you register. Don't click on any other links, just register for the event that's provided in the chat, and you will be able to get a recording of the event. We look forward to continuing this conversation with our next event on addressing social drivers through payment innovation on December 7th. So please make sure you register for that and join us. Again, a link will be provided so you can RSVP there. And as a final reminder, please check out our white paper that was just published on strategies for health plans to support our partners in the effective collection, use, and sharing of social determinants of health and social needs data. And make sure you're registered for our newsletter to stay up to date with all things happening with Blue Shield. And just want to take the time again to thank each of our panelists, and thank you everyone. You all have a great rest of your day. Thank you.